Hello, everyone. It's my pleasure to welcome you all for this webinar on metastatic hormone-sensitive prostate cancer. Just some words to start with. The webinar is organized that way. We have 40 minutes of presentations that will be followed by 20 minutes of questions. So you have all plenty of time to ask all the questions you want to. The only way to ask questions is by using the portal, the question portal, and we'll do our best to answer most of them, if possible, all of them. And as you probably know, to get the CME form for that, it will be done only if you complete the questionnaire following the webinar, and you will receive the questionnaire by email tomorrow. So I'm Nicolas Mottet, and I'm the chair of the prostate cancer panel guidelines. And my talk as an introduction is, what are we discussing now? So these are my disclosures with the pharma industry. Let's remind you what the M classification is. You probably know that the M1 is subdivided into M1A, that is nodal metastasis outside the pelvic, the M1B, which are bone metastases, and M1C, which are visceral metastases, that is mets in the liver, in the lung, etc. We are dealing with the M1 patient group, and pelvic nodes must be considered as N1. I insist on that because in some papers you will see metastatic patients were treated, blah, 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 and if you check carefully, some of them were in fact N1, which is completely different and does not belong to the M1 stratification group. So you said M1, how do we stage M disease? How do we define M disease? Well, regarding old-fashioned imaging, we have the bone scan and the CT scan, and you all know that by heart. Bone scan, the sensitivity is roughly 79%, while the specificity is 80%. But as you know, the sensitivity of bone scan is directly linked to PSA. And the sensitivity is very poor when the PSA is below 10, with the sensitivity roughly 2, up 60% when the PSA is above 20 as a whole. It's also linked to the clinical T stage, and it's also linked to the ISO grading group 4. Regarding bone mets, the CT scan has a sensitivity that is less compared to bone scan, and a specificity which is a little bit less. And regarding visceral disease, we're only using CT scan to assess visceral metastasis. That's what we have done for years. And probably this has changed. We know that PET PSMA had a much higher sensitivity and specificity than bone scan and CT scan. If you're not convinced, but I'm quite sure you are, this comes from a prospective randomized trial published last year in Lancet. When you see the sensitivity of bone scan and CT scan, it's in blue, and the one for PET PSMA is in red. And clearly, the sensitivity with PET is roughly 85% when we're dealing with high risk patients, when it's only 38% when we're dealing with bone scan and CT scan. No question, much more sensitive. For patients that relapse, exactly the same thing. Again, a very prospective cohort, and you clearly see that for PSA value between 0.2 and 0.5, the sensitive rate of PET PSMA with gallium is roughly 38%, and 21% of these patients have, in fact, metastasis disease. Again, the sensitivity is linked to PSA, and the PSA doubling time. This was a prospective cohort. Here we have a well-defined prospective cohort, not fully published, on a quite different tracer, but again, a PET fluor tracer, showing exactly the same thing, that there is a clear sensitivity when PSA is far below 10 or 5. So clearly, PET PSMA is much more sensitive. The question is, so what? We know now that if you use PET PSMA, we will find mets in quite a significant number of patients where we thought initially there were not metastases because of bone scan and CT scan. And I can refer to this editorial I think Cornford published last year in European Urology, that, okay, it's much more sensitive, but it might lead to completely unanswered situations. Let's assume we are dealing with high-risk localized disease with a negative bone scan and negative CT scan. And you perform a PET PSMA, and suddenly you find, I'm referring to this box, 7 spots on the spinal cord, plus an appendicular spots. What do you do now? Will you deny any local treatment on top of ADT? Because the patient has multiple metastases that might be associated with an undertreatment. On the opposite, will you combine ADT plus an ARTA plus a local therapy that might be equivalent to an overtreatment? The same might apply to locally advanced disease. So clearly, we don't know what to do with these results when we're facing this kind of patients. We have much more information, but we don't know what to do with them. And this might lead to undertreatment that might be a completely mistake, or even worse, an overtreatment that might increase toxicity without any benefit. So let me remind you something very simple. All what is available in terms of treatment strategy in M1 disease is only based on bone scan and CT scan. We have absolutely no idea how to use and what to do with the PET PSMA results. And you cannot extrapolate the results of bone scan and CT scan to PSMA results, which is only, I insist on that, only a major lead time bias. So all what will be discussed later on is only based on bone scan and CT scan. Having said that, we know that M1B as a whole is heterogeneous. It's not completely new. In 1998, it was shown that patient that has only actual disease without any visceral metastasis has a much better survival compared to patients with non-actual bone mets or visceral metastasis. The minimal disease are the 2 curves in orange and green, the extensive disease, the 2 curves in red and blue. So the charted classification does not come from nowhere, but from this kind of data. And you know that we are facing an issue with 2 stratifications that partly overlap: the volume classification, which is a charted classification, and the risk stratification that was used only in latitude. Let's go back to the definition. Volume means more than 4 bone metastases, including at least 1 outside the actual skeleton and or visceral metastasis. The low volume are all the others that are not high volume. The risk, the high risk, have 2 between these 3 factors of Gleason equal of 8, 3 bone metastases, whatever the location, of measurable visceral metastasis. If you have 2 of these 3 factors, you have a high risk. If you don't have, you're not high risk, that means you're low risk. Even more important, the M1 situation is heterogeneous and not all the M1 are equal. This is a cohort of patients treated with ADT alone at Dana-Farber Cancer Institute, published 2 years ago. And if you go for the median overall survival, if you compare de novo on the left of the screen and relapsing patients on the right of the screen, you clearly see that the outcome in terms of survival is different. That's especially true if you consider low volume disease based on the charted definition I just showed you. De novo M1 disease, median survival 52 months. Prior local therapy, low volume metastatic, median survival 90 months. So clearly mixing all these patients in the same bag is probably not completely correct. Finally, what do we have in terms of data? Most of the patients, most trials, not all, but most trials included mainly newly diagnosed M1 disease. you have the rate of newly diagnosed M1 disease in the various trials. The only one that included a lot of patients that were already treated locally is the Enzalutamide trial, with 58% only being newly diagnosed. What does it mean? It means that the best evidence we have so far for M1 disease are for those men who are newly diagnosed. It does not mean that there's no place for those who relapse. It just means the evidence is not as good as for the newly diagnosed M1 disease. You might say, okay, let's go for subgroup analysis. Let's go what is observed. Well, what is observed is always, except in one trial, a lack of benefit for those patients who relapse. The only benefit is seen with Apalutamide. I want to insist on something. This is purely subgroup analysis, never pre-planned, never powered. I insist on that, never powered. So it does not mean anything. You cannot use this one to say, well, for those who relapse, there's no place. The only correct answer is, for those who relapse, the power of evidence is very weak. That's the only thing we can say. The lack of benefit might just be because not enough patients were included, because the patients are really different, because it's far too early to see a difference. We don't know, but that's what we have. Finally, what about treating the Mets directly? We have two randomized controlled trials, two very limited ones. The one von Piet Ost published 2 years ago targeted patients who had a normal MRI and only positive on PET choline. The primary objective was ADT for survival, with a tendency to favor metastatic directed therapy. The second one, just published last year, the Oriola trial, where conventional imaging was used, and again, progression-free survival tend to suggest that it was better with targeted therapy compared to observation. None of these two trials, once again, very limited number of cases, none of these trials ever reported a survival difference. That's the only data we have in terms of randomized controlled trial. So in 2020, this webinar will try to highlight the details we have regarding available data. That will be done by Maria. And finally, Philip will try to explain to you how to choose the first-line treatment and how to select the best one for the patients. So thank you for attention. I turn the mic to Maria now. Maria.
Okay, yeah, thank you very much. I will try to share my screen now. All right, so once again, a pleasure, and I was asked to talk about the data we have in 2021 for the treatment of metastatic hormone-sensitive prostate cancer. My name is Maria de Santis. I'm a medical GU oncologist from the Charité University Hospital in Berlin in Germany, and I'm a happy member of the prostate cancer guidelines group of the EAU. And I'm happy to be here together with Nicolas Mottet and Phil Cornford. So to start with, here are my disclosures, and this is my agenda. I will share with you a short introduction and then talk about adding chemotherapy to ADT. I will talk a lot about the STAMPEDE data charted and then adding androgen receptor targeted agents, the ARTAs, to ADT, again discussing STAMPEDE, Latitude, Titan, and Enzalutamide, and I will finish with the guidelines and what we know about adherence to the guidelines. Now to start with, I want to show and remember together with you the outcome and the poor prognosis of de novo metastatic prostate cancer when treated only with ADT. And here we have the 42 months overall survival in the median for those patients in the STAMPEDE trial that were treated in the control arm with ADT only. So here you have the 42 months overall survival. And also of note, the green line is the failure-free survival, which means 11.2 months means that less than 12 months did it take until the patient was progressing and in need of additional treatment. So we see that there is indeed room for improvement. We should do better, and these were the efforts of the last years and many, many trials. I will go into some details within the next 15 minutes with you. The hypothesis was that prostate cancer has heterogeneity and that it may be better addressed by a combination strategy than with monotherapy, with just giving ADT or with surgical castration. And that we should shift our focus towards preventing and delaying resistance with the rational combinations rather than monotherapies in sequence. And this is what happened. And the first large-scale trial that went into that discussion was the STAMPEDE trial. And it is a real success story with the STAMPEDE trial, which is an innovative and unprecedented trial design from the UK led by Nick James. And here in this multi-arm and multi-stage trial, many arms were included, and different drugs were added to ADT to see if overall survival and failure-free survival would be improved. Until now, more than 11,000 patients were randomized in this trial. And down here you see the data that met the first endpoint and support a change in the standard of care for these patients, the metastatic hormone-sensitive prostate cancer patients. ADT plus docetaxel met the first endpoint. ADT plus radiotherapy met the first endpoint. I won't be talking about that one. And ADT plus Abiraterone and prednisone also met the first endpoint. In this trial, also other data were produced that did not meet the endpoint, but still important data showing that there was no overall survival improvement with the addition of zoledronic acid, with celecoxib, or with both. And many more data are to come out of this trial, like combination of Abi and Enzalutamide, like adding metformin, like adding estrogen patch, or targeted therapy. So a very interesting trial that gave us a lot of data and a lot of information for the benefit of patients worldwide. Now, coming back to what we just heard from Nicolas Mottet, is the following. The trials I'm going to talk about, the STAMPEDE trial, Latitude, Charted, they included patients in different clinical trials settings. So in Latitude, for example, where Abiraterone was added to ADT, high-risk patients were included. So there is a definition here. You heard about the definition by Nicolas Mottet. In Charted, high volume and low volume patients were included, like the definition just heard by Nicolas Mottet, and you find it in the right corner down here. And STAMPEDE was special in that trial. Metastatic and non-metastatic patients were included. They had to fulfill high-risk criteria, but here we have a completely different patient population, not completely different, but a larger scale patient population. So just to remind you that we are talking about different trials and different patient populations. Now, going into more details into the trials, let's start with chemotherapy, adding docetaxel to ADT. Starting with Charted, here is the updated analysis of that trial where docetaxel was added to ADT in metastatic hormone-sensitive prostate cancer patients. The primary endpoint was overall survival, and this was highly statistically significant in the ITT population with a hazard ratio of 0.72. going into the subgroups of high volume and low volume patients, it becomes obvious that apparently that result was mainly driven by the high volume patients. I will stop here because this was a matter of a lot of discussions for the last years. Now in STAMPEDE, again, docetaxel in one arm was added to ADT. The primary endpoint here, overall survival. And here you see the ITT population with metastatic and non-metastatic patients. This was highly statistically significant in favor of adding docetaxel with a difference, a median, an absolute difference of the 10 months and a hazard ratio of 0.78. Looking at the M1 patients only, the difference was larger with 15 months and the hazard ratio slightly better with 0.76. Of note, 61% of the patients were metastatic, 15% N1, 24% non-metastatic. Volume data was not collected. So this is the patient population, the ITT patient population of STAMPEDE in the docetaxel arm. Looking at more follow-up, STAMPEDE trial, docetaxel and the overall survival effect after 78 months, so 6.5 years. Here the hazard ratio is 0.81. The effect is still there, statistically significant, but let's say less pronounced. Now, going into the other direction, adding androgen receptor targeted agents to ADT, the ARTAs, as we abbreviate them here. Again, starting with STAMPEDE in the arm G, where Abiraterone, acetate, and prednisolone were added to the standard of care, which was ADT mainly, or also surgical castration in STAMPEDE. The first endpoint overall survival was highly statistically significant, as you can see, with the hazard ratio of 0.6 and a p-value with a lot of zeros after the point. This is the long-term data just presented at the ESMO meeting 2020 by Nick James with a 6-year follow-up. And you see the separated curves here. So very reassuring results after the first presentation of the data with a hazard ratio of 0.61. And here we have 0.6 after additional 3 years of follow-up. All right, so the summary of the updated results of this STAMPEDE arm G, adding Abiraterone and prednisolone to ADT, shows a significant benefit in overall survival, in failure-free survival, in skeletal-related events. So very reassuring data. Now, I think it's also important to look at side effects when we treat patients over a huge period of time with different treatments. And here again, arm G with the addition of Abiraterone and prednisolone. Bottom line here is that even after 4 years, there was no significant difference in worst grade adverse events between standard of care and standard of care plus Abiraterone, and only a slight numerical increase in grade 2-3 adverse events in both arms occurred after an additional 2 years at the 4-year follow-up. So this is also, let's say, reassuring with regards to the adverse events. Now turning to the Latitude trial. In Latitude, again, Abiraterone prednisolone was added to ADT. In this trial, only metastatic patients were included, and they were newly diagnosed and high risk. So a very special and clearly defined patient population. The first endpoints were co-primary endpoints over survival and radiographic progression-free survival. These are the results. Both endpoints, both co-primary endpoints were positive. Overall survival with a hazard ratio of 0.67 in favor of the addition of Abiraterone, and rPFS hazard ratio of 0.47, also highly statistically significant. And for the ADT plus Abi arm, the median was not reached with the overall survival. To complete my overview, I would also like to show you the quality of life analysis presented by Hannah Rush 1 year ago at the GOSCO meeting. In STAMPEDE, over a certain period of time, patients were randomized in parallel to docetaxel and abiraterone prednisolone, and quality of life was measured, and this is what you see here with the green and the red curves. The red curve with docetaxel, you see the drop within the first year, is very similar to what was shown in the Charted trial, where again docetaxel was used. The comparison between docetaxel and Abi shows that the oral treatment with the with abiraterone prednisolone here is better in particular in the first year, but the green curve is also a little bit up also in the second year. So quality of life is pretty good with the addition of abiraterone prednisolone. Summary for quality of life. Now turning to another ARTA, the enzalutamide, I would like to mention the ARCHES trial. Here enzalutamide was added to ADT. This is a trial where the first primary endpoint was rPFS. It was published after 14 months of follow-up. The rPFS, the first endpoint, was statistically significantly positive, but we do not have the overall survival data, and the trial was not powered for the OS. On the other hand, there is the ENZAMET trial. ENZAMET was an investigator-initiated trial led by the ANSOP group, and in ENZAMET, the control arm consisted testosterone suppression plus a standard non-steroidal anti-androgen. So this was special. In ENZAMET, it was not only ADT, and in the investigational arm, testosterone suppression plus enzalutamide was evaluated. The first endpoint was overall survival. In this trial, of note, patients with high and low volume metastatic disease were included, and also docetaxel was allowed and stratified for. You see here the results of the primary endpoint overall survival, which was statistically significant in favor of the addition of enzalutamide, hazard ratio 0.67. So very clear data and a positive result. I don't have the time to go into details here, but we might come back to the data in our discussion. And the last drug to add to ADT in metastatic hormone-sensitive prostate cancer patients is in the TITAN study, Apalutamide. And the TITAN study was a kind of all-comer study. The patient population included here had to have distant metastatic disease by at least one lesion on the bone scan. And that was it basically. Again, here we have a dual primary endpoint of overall survival and rPFS. Here is the result of the rPFS with a risk reduction of 52%, statistically significant, hazard ratio, again, 0.48 in favor of apalutamide. And the overall survival endpoint was also positive. The hazard ratio of 0.67, statistically significant. So again, a positive trial with the addition of apalutamide to ADT. Now, let me end with the data with two summaries. The first summary is about the composition of patient populations in the mHSPC trials with the ARTAs, ENZAMET, TITAN, Latitude, and STAMPEDE RMG. You see that different amounts of patients were included with high volume disease or with high risk disease, as seen here. ENZAMET different from Latitude, where all patients were high risk patients. And also with regards to de novo metastatic disease, in Enzalutamide, for example, only 60% of patients were de novo metastatic in Titan 61. So there were differences and different patient populations included in these different trials. My second summary is shown here, and here you have the different drugs and different trials: Abiraterone, prednisolone, Enzalutamide, Apalutamide, and docetaxel added to ADT. And let's just look at the overall survival endpoint and the hazard ratios. You see that there is a high consistency in the hazard ratios for Abiraterone in the trials Latitude and STAMPEDE, and here also the STAMPEDE follow-up, long-term follow-up with hazard ratio of 0.6. Enzalutamide with the Enzalutamide trial and Apalutamide practically identical hazard ratios of 0.67, again reassuring for this group of drugs. Of the androgen receptor targeted agents, and docetaxel with the addition of docetaxel in the charted trials, Latitude and STAMPEDE, the hazard ratios between 0.61 in charted and updated analysis with STAMPEDE of 0.81. All right, so I think it has become clear that we have level 1 evidence for the use of ADT plus 1 out of 4 options in such patients. And this is clearly stated in our guidelines, in the Oncology ESMO guidelines 2020, as well as in our EAU guidelines. Clear level 1A evidence for the addition of either docetaxel or Abiraterone or Enzalutamide or Apalutamide, as stated here, and addition of radiotherapy will be discussed later on. However, and this is my last point, the real world might be different. And this is shown here in a survey of the US between June 2018 and June 2019. In this survey, it became clear that 81% of the patients were not treated according to the guidelines and just receiving ADT or ADT with a anti-androgen of the old generation. So clearly undertreated metastatic hormone-sensitive prostate cancer patients. Another example from the UK, only 1 in 4 men with advanced prostate cancer received life-prolonging chemotherapy in this survey annual report 2019 from England and Wales. So I think we need to work on these on the real life data as we have level 1 evidence, and I think this is pretty clear. My last question: do really all patients with metastatic hormone-sensitive prostate cancer need ADT plus something? And I think yes. We saw the presentation of Nicolas Mottet before, and this is clearly stated in our guidelines and will also be there in our 2021 guidelines. And secondly, what are the differences between the trials and which additional treatment to choose, as we have different options? And this will be discussed in the next presentation by Phil Cornford. So for now, thank you very much for your kind attention, and I look forward to the questions and our Q&A session afterwards. Thank you very much indeed.
Thank you, Maria. And Phil now will try to clarify how to choose the best treatment option based on what we have. Phil, the floor is yours.
So thank you very much. I'm Phil Cornford. I'm a urologist from Liverpool, and I'm going to try and steer a course through choosing a first-line treatment for metastatic hormone-sensitive prostate cancer. These are my pharma conflict of interest. And this is what we're left with. So we have one option, 2 of these things, 3 of these things. Is there any evidence for it? And exactly where are we up to? I'm going to try and shed some light based on the evidence. And some of this, I'm afraid, will be opinion based because there isn't evidence, but we'll try and discuss what evidence there is. So, who should have it? We've already heard that in the UK we're not very good, and only a quarter of people get a combination of docetaxel and ADT. It's fair to say when that data was collected, docetaxel was the only thing available in the UK, and that might have influenced what was possible. It also matters if they're not fit enough. Remember that those patients who are included in the trials all had performance status 0 or 1. And as a urologist, it's important to try and understand, so what does that look like? And in my fairly simple assessment, if they can do their own shopping, they're definitely worth a discussion with an oncologist about combination treatment. There'll be some people who actually are performance status 2, but that's entirely driven by the disease, and they might get better. But overall, there's less benefit for treating people who are not able to carry out any work and spend more than 50% of their time in bed. And I think that should just be clear before we start. So one of the other things that has been touched upon is, so what about prostate radiotherapy? It was on my original slide, and Maria did mention this was also included as part of STAMPEDE. STAMPEDE wasn't the first trial to show a benefit. It was the first trial to show a benefit, but it wasn't the first trial to try. And here we are. This is the benefit for those people with low volume metastatic hormone-sensitive prostate cancer, which in effect means 3 or bone metastasis, either in the pelvis or in the spine, and no disease anywhere else. And you can see here there is an improvement in failure-free survival and in overall survival in the data here. Well, a hazard ratio of 0.68 for failure-free survival, but not significant for overall survival. So we have all these options. This is really a summary slide looking very much like Maria's, showing you all the different hazard ratios. So the first thing to say is you can't just look down the hazard ratio and say, ah, yeah, well, the hazard ratio for latitude was 0.6 and for STAMPEDE was 0.61, and therefore it is the best drug, because these are not a head-to-head comparison. So that isn't valid. What we can say is that they're all effective, and that's probably as much as we can say. The next temptation is to look at all the side effects, and this is just a list of the side effects as they are in the BNF in the UK, which is our sort of Bible of side effects for drugs. And those side effects are very different, and on that basis, you can make a decision based upon that. But these side effects are not collected in the same way, and so strictly, they haven't, this isn't, again, is not head-to-head data, this is just comparative data looking at different studies. We did mention something about disease burden. The Latitude study looked at only people with high volume disease and high risk burden. But in STAMPEDE, they subsequently evaluated low risk and high risk disease. And it would appear here that disease burden doesn't make a difference. It's not just that there is a difference. It is effective for those people with high risk disease. And so Abiraterone appears to be effective for both low risk and high risk disease. So docetaxel was first, Abiraterone was next. Is there any data? It's just a little bit of data. For nearly 18 months, people were randomized in STAMPEDE against standard of care, and you could have been randomized to either docetaxel or abiraterone. And so there's a small cohort which have been discussed a lot, considering they are a fairly small cohort of patients. But at this point, patients were being randomized to one or other. But it's not really a direct comparison. It shows that there is an improvement in failure-free survival with the advantage for abiraterone, largely driven by PSA. There is a difference in failure-free survival, but no difference in overall survival. And if you look at all of the endpoints, you can see that there is reasonably strong for progression-free survival, actually not statistically significant for metastatic progression-free survival, no difference for skeletal related events. And when we talk about cancer-specific or overall survival, there was no difference between these groups. And this is really only head-to-head data. Of course, the other thing that you might have noticed is that in the Enzalutamide trial, because docetaxel was already considered to be standard of care for people with metastatic hormone-sensitive prostate cancer, about half of the patients had actually been given docetaxel before they were randomized to either an enzalutamide or an anti-androgen. And if we look at this, so in this, the blue line is progression-free survival. These people had had docetaxel up front in this subgroup analysis. And interestingly, there is no benefit for having both in the overall survival, although there was a difference in PSA progression-free survival. So it doesn't appear to be that the combination of docetaxel and a novel hormone makes a benefit. So then we're left with indirect comparisons. And you'll have seen a number of analyses published trying to explain how one drug was better than other drug. The important thing about this is all indirect, and as a consequence, is mainly hypothesis generating rather than proven. But there are a number of different meta-analyses that have been done. This was the first one, looking at abiraterone versus docetaxel. And the suggestion here was for patients in the probability that abiraterone was better than docetaxel for overall survival was somewhere between 70 and 85%. And for progression-free survival, that rate was higher. And if we graph it, it looks something like this. But interestingly, there's still quite a lot of overlap between the different groups. So here we have a plot showing the effectiveness of other treatments and comparing it with docetaxel, where the effect that you saw with docetaxel was 1. Of course, docetaxel is effective as a treatment, but what happens if we try and understand whether the other things are more or less effective? Abiraterone, enzalutamide, and apalutamide at the top here And ADT alone, which we know to be less effective, is at the bottom. And you can see it is statistically different. But just about everything else crosses the midline. This study included enzalutamide because it was later, and it suggested that enzalutamide had a 77% probability that it was the preferred treatment. Here again at the top, you can see the different Abiraterone, Apalutamide, and Enzalutamide compared with docetaxel as an indirect comparison of overall survival. And then this is ranked, their probability at this part of the graph, and you can see the chance that this is enzalutamide is the rank one is the most likely thing statistically. But this isn't a comparison. Even more interestingly, if you just include the low volume disease, because here the low volume disease with enzalutamide didn't actually cross zero. And if you do enough cuts of the data, you'll always find something that is positive. It's not the same as proving that it's true. So what about progression-free survival? We've looked at the overall survival data. What about progression-free survival? Is there the same trend? Here again, you've got apalutamide versus ADT alone at the top, and clearly that's a lot better. Docetaxel versus ADT plus ADT versus ADT alone, less good, and then one versus the other. And the suggestion that apalutamide for progression-free survival is slightly better, but again, this is indirect comparison. And again, if we look at the effect of docetaxel from this later study, see here's ADT alone. This is the effect of docetaxel, and these are the novel anti-androgens. And it certainly would appear for that progression-free survival appears to be favour novel anti-androgens. Now this data you've seen a little bit because this is about quality of life. And again, it suggests that quality of life for patients who have apalutamide is maintained better than quality of life of those with docetaxel. I think some of us thought that you could have your docetaxel early, get all of your side effects in at the beginning, and then your quality of life would improve, and that what you risked with apalutamide was a slow decline. But the studies don't really support that. So what else do we have on quality of life? So this is, again, indirect comparisons for high-grade adverse events. So if you have COX-2 inhibitor, you don't have very many adverse events. But then, of course, it doesn't work. You actually have more adverse events with docetaxel than you do with ADT. But again, ADT doesn't work. The interesting thing is that as we come down this with apalutamide and enzalutamide, you see there is a significant decrease in adverse events as compared with docetaxel. And that clearly is provoking, if not proven. So you need to have something we're clear about that. Should you have enzalutamide or apalutamide? This data came from the St. Gallen's consensus panel meeting. And there was a suggestion that those people with a history of falls, with baseline fatigue, with any neurocognitive impairment should have Abiraterone. 85 to 95% of the panel agreed. And for those people with cardiac ejection fraction below 50%, acute liver dysfunction or diabetes, then increasingly people suggested they should have enzalutamide. But this is consensus. This is what people feel is true, but there's not any evidence, and therefore, as a guideline, you can't support that. So what can we say? We can say there's no doubt that men presenting with metastatic disease benefit from combination therapy. There is no doubt that men presenting with low volume metastatic disease benefit from local treatment, although they don't get overall survival. No evidence that an androgen, a novel androgen-directed therapy, is better than docetaxel at improving overall survival, but it is possible that they may be associated with lower risk of higher grade adverse events. So I hope that made you think. Thank you very much for your attention. And now back to Professor Mottet.
Thank you, Phil. So thank you both for your efforts. In the meantime, you were talking, we received questions. And let me try to summarize these questions to you. And I will start with Maria with something that might be easy. There was a question regarding the difference between enzyme APA. Is there really a difference? And if yes, which one?
Okay, this is the most easy question for me, right?
Yeah, let's start with something simple.
So, as a matter of fact, we don't think that there is a huge difference with regards to efficacy between the two drugs when it comes to the way of function of the drugs. But of course, the trials and the data are a little bit different. And bottom line is that I think that there is not a lot of difference, but we don't have a head-to-head comparison, of course. As for the side effects and for daily use, I don't think there is a lot of difference. There are a few more dermatological side effects described for Apalutamide, but in the meantime also for Enzalutamide, there is some more rash described and added to the list. So bottom line is that I don't think that there is a huge difference, but this is not the data we have, but this is just kind of daily practice, I think.
Then it's a question for both of you, and you might start with in the order you prefer. Two people with their name pointed the fact that there are some difference between the ESMO and the EU guidelines regarding volume and regarding relapsing or no relapse. I don't know who will start with the answer.
Go on, I'll start with that. So there are some differences. I think, as we've shown, there is a lack of strong data for the relapsing. It's not that there isn't any data for relapsing. It's that the data isn't quite as strong, and the EAU has taken a view that if you're going to have a strong recommendation, then you need to have effective randomized data. I think ESMO has decided that they like the data. There is data out there, and as a consequence, it's a slightly different slant that they've put on it, I would say.
Okay, Maria, do you want to add something on that?
Well, I think, of course, we don't have very strong data because not so many patients were included in the trials, but both patients that were relapsing and more patients that were primary metastatic were included in the trials. But when we look at the ITT population, of course, also relapsing patients were included in most of the trials, not in Latitude, but in most of the others, and in particular, STAMPEDE, they were allowed. So I would not exclude patients from treatment just because they were relapsing if they really show aggressive disease at the time of relapse when being hormone sensitive. Just as a practical remark from my side.
Perfect. Let me select where, as expected, we have questions regarding PSMA. That's not a surprise. I will start with the answer because that was one of the first questions that was asked. The question is, are you saying using PET PSMA leads to lead time bias? Yes, exactly. What you are doing when you're using a more sensitive tool compared to a less sensitive tool means you see disease much earlier than when you have. So if you want to prove that the benefit to see earlier is there, there's no other way than doing a randomized trial based on these results. I'm not sure it will be ever done. I'm not sure it's either feasible, but clearly, this is a clearly lead time bias, and it might be a major lead time bias. There might be tens, not to say years, between what you see in PET PSMA and what you see on old-fashioned imaging. Remember, high-risk disease, negative bone scan, negative CT scan, when the PSA is there, the sensitivity is almost 60% with bone scan and CT scan, where it is 90% when PET PSMA. So there's no question, there's a huge lead time bias. And this leads to us to the question that what are we doing for patients when you only see metastases on PET PSMA? I don't remember exactly how the question was asked, but it was something like that. What do you do in practice when you see disease on PET PSMA alone? Let's start with Phil.
So of course the answer is that you don't know what to do with it. That's the problem. So here is this patient, and they've got a positive PSMA PET scan. They often have reasonably high-risk disease anyway, because that's why they've got metastatic disease. They clearly have prostate cancer somewhere else. There is a small chance that that PSMA PET is a false positive. So it's not guaranteed that that is metastatic disease without, and there is still a small chance that that one or two spots that you've seen on a PSMA PET isn't actually cancer anyway. There is no doubt.
Yeah, keep going.
Yeah, there is no doubt that in addition to that, there is also a temptation to do something, because you can't unknow what you've found on a scan. And so in Liverpool, we have free and easy access to PSMA PET scanning. I can have a PET scan every time I like. There is no limit to it, and it doesn't cost the patient anything because it's all free. So on that basis, I can easily have a PSMA PET. But then you tend to do something that is outside of the guidelines, because there isn't really a guideline for what to do with these patients. So some of these patients get locally directed therapy if they've only got a small number of metastases. Not that there's any evidence for that at all. And then if you've got a lot of metastatic disease, then people talk about whether they should have both local and systemic therapy. But again, there is absolutely no evidence out there, and you're left saying, I don't know what else to do. I have begun to start doing bone scans on them, because if the bone scan is then positive, I think, but now I know what to do, because now I've got a post-scan positive patient, and so that's all right. So now I know what to do with them. Because they turn up not only from ones that are in my clinic, but people get referred in, and then they say, okay, so now what we're going to do with it. And I sometimes do a bone scan and a TC scan so that I can have a definitive stage to try and work out what to do with them, because I can say the evidence is this, but we don't really know how that applies to you.
Maria, would you like to add something? Because in Germany, everyone has a PET PSMA.
Well, at least many, not anyone, unfortunately. But what I do in those patients is definitely not asking for a bone scan. I could not do that, I'm sorry. But I look for a correlate on the CT part of the PET-CT. So if there is a CT correlate with clearly osteosclerotic lesions, and there are multiple sclerotic lesions, I would say this patient is definitely metastatic. There are several bone metastases. I don't look at the bone scan, and I would treat this patient. It might be different if it is oligometastatic, let's say only 3 tiny lesions, then I might tend to do ADT and local therapy, local radiotherapy only. But I think it is worth looking into the detail of the PET-CT and not only look at the shining lesions, at the little stars.
Sounds very wise. There's a question that is for Phil, but this one I promise is simple. Local treatment, does this also apply to radical prostatectomy?
So again, there is no evidence for radical prostatectomy in this setting. Lots of people are trying to collect the evidence to suggest that it might be effective, but at the moment, the only evidence is for radiotherapy.
Probably we have time for one last question because before we conclude, and the question is absolutely provocative. What is a good response for mHSPC patients? And the question is for Maria. The question is it reaching a PSA below 0.2, having an objective response, both criteria or some different criteria? And so what is a good response from mHSPC when you treat them?
Well, I think the question is the one that I don't really ask, because we don't have the data to support and to have a correlation to the overall survival, because what we would like to see is maybe a hint towards the result concerning OS, which we don't have. We know from the ADT data that a reduction of PSA by 90% is a positive sign with regards to prognosis, but I think this is the best we can do. I usually don't look at other responses. I look at what we do with the prostate cancer working group criteria at progression and signs of stabilization and progression to change treatment, but not to other response criteria.
Okay, so I'm afraid we have to conclude now. Back to simple things. In 2021, probably there's a strong recommendation. That's before printing, but I can show this to you because there's a final version. Discuss combination therapy to all M1 patients, that is newly diagnosed and those who relapse. Discuss the combined treatment, and you can see it's a strong recommendation. Probably even more important is that do not offer ADT monotherapy to patients whose first presentation is M1 disease if there is no absolute contraindication for combined treatment. Clearly, this should not be done. ADT monotherapy has almost no place left. It should be reserved to those men unwilling or not able to receive a combined therapy. Remember what Phil showed you regarding UK practice and what Maria showed you regarding US practice. Clearly, the absolute improvement will come with this. The second thing is, in 2021, we have several options. Chemotherapy, Abi, Apa, or Enza, all these treatments are strong recommendation for patients whose first presentation is M1 disease. It's strong for those men because, as we showed, the vast majority of the trials included these men. An alternative is to combine ADT plus prostate radiotherapy, but only for those men who belong to the low volume disease by charted criteria. there are strong recommendation not to do any combined ADT with local therapy in patients with high volume. There's a strong recommendation to not combine ADT with surgery in M1 patients outside a clinical trial. There's a strong recommendation not to give metastasis-directed therapy to M1 patients outside a clinical trial or a well-designed prospective cohort study. These are the basis of the EAU guidelines for now, and to be honest, they are very close to the ESMO guidelines. Some details are different, but these are the basis. You can see we were not able in the guidelines to say treatment A should be considered first-line therapy and standard of care, just because we don't have data to support that. So we have several options. Every option has its pros and cons, and every option should be discussed with the patient provided they're able to receive that. To conclude, I've been asked to show this to you. It's an educational online website made by EAU. And if you're interested in ADT in prostate, you have 5 courses that are available. 4 of them are online now, regarding details of all what has been shown to you. By this, I want to thank you all for your participation. And it was my pleasure, and I hope it was your pleasure too, to be there. And by that, thank you all, and have a good evening.